So this is part 2 of chapter 21, which is about the blood vessels. And we talked about different blood vessels, and I told you guys to remember the different names for the different blood vessels. What did we call the large arteries? What's the other name for the large arteries? The main arteries, the aorta, and the main branches. Is it resistance? Is it capacitance? Is it muscular? Is it elastic? Elastic. Yes, it's called elastic. Which ones are the muscular? The mid-size or the arterioles or the capillaries? Yes, it is distributors, but which one is it? Mid-size or arterioles or capillaries? Mid-size are the muscular ones. Yes. What are the capacitance ones? Capillaries are exchange. Capacitance, capacity. Yes, the veins. The veins. Okay. And what's the unique about the sinusoids? It's the only one that contains something that nothing else has. Does it just contain the regular pores or something more than that? It contains gaps, gaps. The only one that contain gaps, not just pores, tiny pores. It's gap, a missing area, gap. Okay, what's unique about the veins that help them, or what are the factors that help the veins move the blood up against gravity until it reaches the heart with the very low pressure? Valves, that's one. There are another two. Yes, the negative intrathoracic pressure that suck the blood up. One more, muscle contraction. Yes. Okay, so now elastic rebound is basically when the blood moves into the elastic arteries, it absorb the pressure that's pumped into it and then rebound to push it so that it moves forward. So this is the stretchability and rebounding, which is a characteristic of the main arteries. And that's why we called it the elastic arteries. Um, what's the main arterial pressure? What's the pulse pressure first? If you guys are studying as we go. Pulse pressure. You measure it in the arteries, but what is it? How to get it? What are the two numbers that you need to get it? Systolic and diastolic. It's the difference between those, right? How about the MAP, the main arterial pressure? How to get it? Something plus something. Diastolic plus, no, diastolic plus systolic, that's the whole thing. 1/3 of the pulse. 1/3 of the pulse. Meaning, if systolic is, let's say, 120, okay, and diastolic is 20, just to make it easy. What's the difference? 60. What do you call the 60? Pulse pressure, right? If I ask you what's the MAP or mean arterial pressure, it is a diastolic, which is 60 plus third of the pulse. So that will be 80, right? I always give you guys these questions to know exactly where you stand. If you remember everything, you're perfect. If you don't, if you remember part of it, you need to push more. If you don't remember, you need to put a lot of time and work. All right. So, anyways, we're going back. Venous return. I talked about the venous return. Venous return, the blood returning to the heart through the veins, which is moving towards the heart. We know that the veins are low pressure vessels, right? Which part of the veins is the lowest of all? Inferior vena cava. This is close to zero, right? So what exactly help it is what I told you before. There is the negative intrathoracic pressure. It suck it up but we call that respiratory pump. And you should remember this term specifically, respiratory pump. This is what pump it up, the blood, against, most of the time, against gravity. Otherwise, there is muscular contraction and the muscular contraction and the valves. Now, the capillary exchange. This part is kind of a little bit complicated, but not that much. I will try to simplify it as much as possible. We call the capillaries the exchange vessels, isn't it? We have another name for every single one of the blood vessels, right? For the capillaries, we call it the exchange vessels. Why? Because this is where we do the actual exchange. Exchange means something goes out in front of something going back. Isn't this is what exchange means? So what happened at the capillaries only at the capillaries, nowhere else. Started from the heart, going through all these arteries and going back through the veins, everything. There is absolutely no exchange. The blood doesn't leave, the blood doesn't come back. Nothing. It's called conduction. It just take it from here to here. That's it. Nothing go out, nothing go in. The only spot in which there is an actual exchange are the capillaries, and that's why the capillaries are one cell layer. It's very thin to allow things to go out and things to go in. So let's think about it. The blood is in the left side of the heart. Is that oxygenated or deoxygenated? Oxygenated. So it goes from the left side of the heart, from the left ventricle to the aorta, right? Large vessels, mid-sized vessel, arteries, and then the arterioles, right? Until it go to the capillaries. Which side of the capillaries? The arterial side of the capillaries, right? Are we good so far? So now how the exchange is going to happen? What is going to leave the capillary bed that's oxygenated? Remember, it's oxygenated. It goes all, it is still oxygenated, no change. From the left atrium to the left ventricle to the aorta to the large size arteries, mid-sized arteries, arterioles, capillaries. Did we change anything? Absolutely nothing, right? So until you reach the capillaries, it's rich of oxygen. So now the exchange, what's going to leave the capillaries and move out? Move out where? What is surrounding the capillaries? It's the different cells, the body cells. This is what actually go to the cells to do the exchange there. It's conducting it. So I just mentioned that it's full of oxygen. So what's going to leave the capillaries and go to the spaces in between the cells so that the cells take it? Oxygen. Yes, oxygen, right? So what leaves out? Oxygen. What else is carried on the blood that leaves and go to the cells? Nutrients, right? What the cells need. All the cells need, they just need water, nutrients, oxygen. That's it. This is how the cells survive, right? This is all what they need. Water, nutrients, oxygen. This is what's going to leave the capillaries and go in between the cells, and in between the cells, we call it interstitial fluid. Are we okay so far? Now the cells took those three. The cells, it leave the capillaries, go to the spaces, interstitial fluid. It's fluid. In between the cells, it's not empty, right? We know that from 233. There is fluid in between the cells, right? So the capillaries, oxygen, nutrients, and water, it doesn't leave the capillaries and go to the cells. It go to in between the cells first to that fluid, and from there, it go to the cells, right so far? Now the cells take it. Then what? The cells are going to take the nutrients and the oxygen and use the oxygen to burn the nutrients, especially glucose, right? Isn't that how we get our energy? You get the glucose, you get the oxygen using your mitochondria, burn it, get energy, and this is what you need, right? What is the end product out of this process? What happened when you burn the nutrients? CO2, carbon dioxide, any waste products, whatever it is, right? So this is what is produced out. This is what's going to go back to the capillaries. So we're exchanging now oxygen, nutrients, water out, and then carbon dioxide, waste products, and water in. Now, how does it leave and come back at the same time? It leaves at the arteriolar end of the capillaries. go to the cells. And then it go back from the venular side of the capillaries. Do you remember those ends? So it leaves from here, goes out, and then it goes back from the other side. What are the factors that help that to happen? Like what push it out? What are the mechanics of this to happen? Well, number one is the hydrostatic pressure. The hydrostatic pressure, we talked about it before. Remember, we said there is arterial pressure and venous pressure and capillary pressure, and we called it hydrostatic pressure, right? So the hydrostatic pressure in the capillaries that's pushing the fluid of the water of the blood out. And there is fluid outside of the capillaries, right? Interstitial. So there is hydrostatic pressure in the capillaries and hydrostatic pressure in between the cells. Which one is higher? Capillaries or interstitial? And why? Capillaries is higher. Why? Because it's just coming from the heart. This is closer to the heart, right? The pressure, it goes from the heart, let's say 100, 80, 60, 40, 30, 20. By the time it reaches the arteriolar side of the capillaries, let's say it is 30. How about the interstitial fluid? It's almost nothing. What is pushing it, right? It's very low. There is no heart there. There is nothing. It's just some fluid in between the cells. So the hydrostatic pressure there is very low. Are we following so far? So this is the first force that's going to push the fluid out. Like I'm pushing the door, trying to open it, and you're pushing from the other side, trying to close it. Whichever of us is stronger will end up pushing to on his side, right? If I'm pushing out, you're pushing in, I'm stronger than you, I push out, right? So the hydrostatic pressure inside the capillaries is pushing the fluid out, but the interstitial fluid is pushing in. It also has its own pressure, even if it's low. The difference between those is called net hydrostatic pressure. Pushing out is 30, pushing in is 10, so the net is 20, 20 in or out. 30 in the capillaries and 10 in the interstitial fluid. What's the difference? 20 out of the capillaries or into the capillaries? Out. This is the first force. Is that clear? Net hydrostatic pressure. That's one. It's not that simple. There is another force. The other force is oncotic or osmotic pressure. Do you remember if this fluid is more concentrated than this, the fluid will move from less to high, from low to high? Do you remember this? Do you remember blood cells in 233 when you put it in the solution? Do you remember these? Okay, so here is what's happening. Inside the capillaries, there is osmotic pressure. Outside of the capillaries, there is fluid, so there is also osmotic pressure. Which one is more concentrated? In the blood. Why? Most importantly, because the plasma proteins, these big chunks, they don't leave the capillaries. Do you remember when we talked about these capillaries? The pores are too small, barely tiny things can leave. Plasma proteins, this is a big bulk. It cannot leave. So because of mainly because of that, the osmotic pressure inside the capillaries is higher than the interstitial fluid. Does that make sense? Does it make sense? Which one is more concentrated, in the capillaries or outside? Inside the capillaries. Why? Plasma proteins. Clear? So now the fluids will move from the interstitial fluid into the capillaries, right? So I have two forces now. The difference between the osmotic pressure inside and outside, we also call it net osmotic pressure. So how many pressures do I have so far? Two. There is hydrostatic pressure, the net, the difference, and another net, the difference between osmotic in and out. Then the net hydrostatic is pushing out, right? The net oncotic or osmotic is pushing in. Is it going to move out or in? It depends on which side are you talking about. At the arteriolar side, the net hydrostatic pressure is a lot higher than the oncotic pressure. So the fluid part, I'm not saying the blood leaves. I can't say that. The blood doesn't leave the capillaries. Part of it, just water, oxygen, carbon dioxide, tiny things. Like if you think about it, what's water? Three atoms, right? Carbon dioxide, 3 atoms. Oxygen, 2 atoms, right? But if you're talking about plasma proteins, this is a long, big chain of amino acid. Each amino acid consists of a big number of atoms. It's huge, right? It cannot pass. It cannot go through it. So the bottom line is, at the arteriolar side, the net hydrostatic overcome the net oncotic. So the fluid part of the blood leaves. Clear? It go to the cells. Cells take their needs. What their needs? The good stuff. Let's call it the good stuff. The good stuff means nutrients, oxygen, and water. Clear? They use it. They produce waste products and carbon dioxides, the bad stuff. The bad stuff on the other side, and at the venular side, remember in the venular side, the hydrostatic pressure is lower, isn't it? Do you remember this rule? Aorta, high, down, 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 down. At the arteriolar end, it's low. At the venular end, it's even lower. At the veins, it's lower. At the inferior vena cava, it's almost zero, right? So the more you move away from the heart, the lower the pressure is. Clear? So at the other end, the osmotic pressure that's pushing in is higher than the hydrostatic pressure that's moving out. So the fluid end up moving back in. Did you get this motion? So the fluid leave from one side, not the whole blood, fluid part with the good stuff. Leave because the net hydrostatic is higher than the net osmotic on the arteriolar side. Now the fluid is outside. Cells will take their needs, release their bad stuff. On the other end, it return back. Is that clear? It's not just that. Here is to make it even harder. Okay? As if it's not hard enough already. So to make it harder, I will tell you that the amount that leaves is not equal to the amount that goes back. Okay, like 10 milliliters leave and only 7 go back. So how about the 3? It's in there, right? It's in the interstitial fluid, isn't it? So what happened to it? There are lymphatics, another route, lymphatics, other types of capillaries that will take the remaining through the lymphatic system, returning it to the heart. Why? Why don't you just make it 10 out, 10 in? That's it, we're done. No, this is happening intentionally, that the amount that leave is not equal to the amount that goes back. We intentionally want part of it to stay in between the cells in the interstitial fluid. So these fluids, the extra fluid that's staying in, they will not have any other choice but to exit through the lymphatics. Why do you want part of it to go through the lymphatics? To be cleaned. What's the lymphatic system for? Do you remember the lymphatic system? Generally speaking, why do we have lymphatic system? Immunity, cleaning, right? Killing pathogens, right? So this is a good thing about it. The extra part that didn't go back will go to the lymphatic capillaries and then go to the lymph circulation. As it is moving back to the heart, the lymphatic system is going to clean it, filter it, kill the pathogens, kill the waste products, cleaning it. To the next cycle, part of it will go to the lymphatics, clean it. Next, 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 the whole blood will be clean. Does that make sense? Make sense? Okay, let me give you a tiny scenario here. Last thing. 10 milliliters are leaving, okay? 7 are going back, and the 3 go back through the lymphatics. What if there is something wrong with the lymphatics that's closing it? So only 1 go back. The 2 will be retained. It's going to stay in between the cells, right? Where did it go? 10 leave, 7 and 1. We end up having 2 in between. It didn't go anywhere. You know what do we call this condition? This is a condition that's not normal. What do we call it? This part is going to swell. There is a name for it. Not inflammation. Edema. Yes, it's specific. It's in this case, it's lymphedema. Yes. So this is called, generally speaking, it's called edema. That the scenario that I described is lymphedema, as he mentioned. So, did you ever see somebody having his one of the foot or two of them are swollen, and then most of the time it goes away? If you see that before, this is edema. Part of the fluid is trapped. What I told you is one of the scenarios. Here is another scenario: pregnancy. Don't you see pregnant ladies sometimes have their foot swollen? Did you ever see this before, and then it goes away? Yes, this is also edema, but this is temporary edema for another reason, not the lymph. What's happening here is 10 leave, 7, 3. This is normal, right? 10 leave, and instead of 7, only 4 or 5 go through the veins. Why? Because the baby is pushing on the inferior vena cava. The baby is here, right? It's pushing on the inferior vena cava. So this is making it's already hard. Do you remember how the venous return goes? Against gravity, it's already hard. The pressure is low. Muscle contraction, valves, right? All of this is barely moving the blood back to the heart. What if you have a baby that's pushing on the inferior vena cava? Even harder, right? So this is also called edema. So remember this term. So the moving of material can be diffusion, filtration, and reabsorption. This is the three ways. Diffusion is the ions. The ions leave by, I just give you a general idea. It leaves and it goes back. But to be more specific, what do you mean by leave? If we're talking about the ions, it goes by diffusion. Let me tell you this. What exactly leave the blood and go through the pores? Anything that's small enough to fit into these pores, right? What is small enough to go to the pores? Anything that's tiny, water, 3 atoms, right? Oxygen, carbon dioxide, also ions. Ions is 1 atom only, right? So how about the atoms? One atom only. Yes, that's very small. So all of that is going to go out anyway. Plasma proteins and blood cells, no, too big. Okay, do you remember now what's leaving? What can exchange? Everything that is tiny. 1 atom, 2 atoms, 3 atoms, 10 atoms, maybe. More than that, no. Okay? Plasma proteins, too big. Cells, too big. Clear? Okay. Now, what push the ions out? I already gave you the forces, right? But it's easier for the ions to leave from the blood and go in between the cells because of the concentration gradient. Like if sodium and potassium are leaving and going to the interstitial fluid, it's because of the concentration gradient. There is more in the capillaries than interstitial fluid. We call this movement diffusion. So what's a diffusion? Diffusion is passive movement from high to low concentration. We call that diffusion. This is the first way of moving, okay? So here is ions, sodium, potassium, calcium, chloride, whatever it is, oxygen, carbon dioxide, water, uh, even small compounds like glucose, like amino acids, these tiny things, that's okay. But the big things, no. So if I'm you, I would rather memorize what doesn't leave. That's easier. Cells and plasma proteins. Everything else, it can leave. Everything else is small enough to leave. Okay? And instead of memorizing how many sedan cars can go into this room and the rest are trucks that cannot, just know that the trucks doesn't leave. What are the trucks here? Plasma proteins and cells. They cannot leave. Everything else, yes. Ions, yes. You don't have to memorize the names. Ions in general. How about water? Yes. How about oxygen, carbon dioxide? Yes. Anything that's small enough, it will go through. Plasma proteins? No. If there is a spot in this whole entire, I'm not, this is the capillaries. That's it. But if there is a spot in all this circulation that allow plasma proteins to go through, which one have gaps? Sinusoids. So this is the only time that the plasma proteins can actually leave and come back. Filtration is what I was talking about. This is the one that's driven by the hydrostatic pressure. Okay, so hydrostatic pressure, remember hydrostatic pressure in and out, and there is a net, and there is a concentration gradient, which is osmotic pressure. And then going back, the opposite of filtration is called reabsorption. And reabsorption is mainly by osmotic pressure. This is just explaining what I just told you. I told you the general idea. Things are going to leave the capillaries and go into the interstitial fluid. What's the force? The main force pushing out? Hydrostatic pressure. Net hydrostatic is more than net osmotic. Clear? How about the reabsorption? Going back, the opposite of filtration. The net hydrostatic is higher than the net. The net hydrostatic, no, the difference is higher than the net hydrostatic, right? Net hydrostatic on the arterial side is more than the net osmotic. This is the arterial side, fluid leave. How about the other side? Net osmotic is more than the net hydrostatic. It goes back. Going out, we call it filtration. Going back, we call it reabsorption. Is that clear so far? So we talked about filtration, moving out, reabsorption, coming back, and the last one is diffusion, which is ions. So you will see a lot over here, but I told you what you need to know already. Okay, so there are other things, but that's okay. Here it is. Net capillary hydrostatic is higher than the net capillary osmotic on the arterial side. And then it's the opposite for the venular side. I make it as understandable as possible. And that what I told you is enough. It's you will see a lot of details, but this is basically what I want you to know. Here it is again, just to summarize. Look at this. This is the arteriolar side, right? Fluid is moving into the capillaries. Inside the capillaries. Inside the capillaries at this end, is the fluid leaving or coming back? Leaving out of the capillaries or coming back to the capillaries? Leaving out. We call that filtration. Filtration. Look at this. Look at the cells. Here are the cells. The cells take what they need and produce the waste products, what they don't need, waste products and carbon dioxide. So now it's going to go back. What do we call going back here? Reabsorption. And what's higher here? Net osmotic or net hydrostatic? Osmotic. Hydrostatic push out. Oncotic push in. In this end, net hydrostatic is higher. It push out. Filtration. In this side, net osmotic is higher. It goes out. Okay? Is it all of it goes out? No, part of it goes to, look at this, lymphatics. To be cleaned, get rid of the bad stuff. Now, what are the factors that affect the hydrostatic pressure? What's hydrostatic pressure? It's the pressure inside. Inside what? Capillaries. Yes, inside the capillaries. We call that hydrostatic pressure, right? The pressure, again, the pressure inside the arteries, arterial pressure. The pressure inside the vein, the blood pressure. Inside the arteries, arterial blood pressure. The blood pressure in the veins, venous blood pressure. In the capillaries, hydrostatic pressure. Capillary hydrostatic pressure. It's the same thing. Pulmonary hydrostatic, pulmonary pressure. Arteries, arterial pressure. Veins, venous pressure. Pulmonary pressure. Capillary, hydrostatic pressure. Okay, so hydrostatic pressure, which is a continuation of the arterial blood pressure, isn't it? It's the same as arterial blood pressure, but it's not in the arteries, it's just in the capillaries. So hydrostatic pressure, does this pressure, can this pressure change? Can it go up and down? Yes. Do you remember the blood pressure? Can the blood pressure, we talked about it, right? Can the blood pressure goes up and down? Of course. Remember the contractions, the cardiac output? Do you remember this? So what can lower the blood pressure so that reflects on the hydrostatic pressure? How about losing some of your blood, hemorrhage, right? How about dehydration? If you think you're if you are dehydrated, do you think your blood pressure stay the same? Of course not, right? What shrinks? Blood volume. Blood volume. Guess what? If your blood volume is 5 liters and you are thirsty, dehydrated, do you think it's still 5 liters? Of course not. It's 4.5, it's 4, whatever it is. It's not the same. So when the blood volume goes down, what happened to the blood pressure? Goes down. What happened to the hydrostatic pressure in the capillaries? Goes down. So less force pushing out. Okay? Less force pushing out. So there are factors that increase and decrease the blood pressure. One of them is the blood volume. How about the viscosity? Higher viscosity, does that increase or decrease the blood pressure? Viscosity. If it is more viscous, thicker, it increase the blood pressure. If it is more viscous, it have more effect. It increase the blood pressure. Less viscous, if it is diluted, it's less pressure. Okay, remember it. If you do vasoconstriction, does that increase or decrease the blood pressure? Constriction, increase it. Vasoconstriction, increase it. How about heart rate? If it increase or decrease the blood pressure? Why? Because what increase if the heart rate increased? There is a specific name, goes by number. When the heart rate increase, what increase as a result? Huh? Close. Not exactly. Cardiac cardiac output? What's a cardiac output? Heart rate times what? Oh, you forgot it. Huh? Not called a systolic pressure. It starts with S, but not systolic. Stroke volume, yes, stroke volume. What's the cardiac output? Isn't it stroke volume multiplied by heart rate? Are you guys studying as we go? Heart rate multiplied by stroke volume. Heart rate increase, blood pressure increase. It's multiplying, right? So heart rate increase, blood pressure increase. How about the stroke volume? If it increase, what happened to the cardiac output? Increase, right? Stroke volume increase if your blood volume itself increase. How my blood volume increase? There are different ways. What if you are overhydrated, like you're drinking a lot of water? Doesn't that increase your blood volume? So that will increase the stroke volume, increasing the cardiac output. When the cardiac output increase, what happened to the blood pressure? Increase, right? Okay. So I hope that makes sense because this is pure physiology. So it's just understanding. Okay. Vasomotion is a term that's given to vaso motion. Vaso is vessels. Motion is movement, right? Contract, relax, contract, relax. This is called vasomotion. So vasomotion is a term that apply to the pre-capillary sphincters. I showed you that in the picture. Do you guys remember? Arteriolar side, and then capillaries, and then venular side, right? At the arteriolar side, there are sphincters. It can open and close. More blood, if it open, blood go to this capillary bed. If it contracts and close, less blood go to that capillary. It keep on opening and closing. We call that vasomotion. Now, what is controlling the blood pressure? This is repeating again, okay? But the part that's not repeating is the autoregulation. What's a regulation that we talked about before? Nervous system. What's the effect of sympathetic? Does it increase the blood pressure or decrease it? Increase it. How about the parasympathetic? Decrease it. This is called the nerve control or the neural control. Do you remember this? Chemoreceptors and baroreceptors, right? If the baroreceptors detecting that the blood pressure is dropping, it will send the signal to what are the centers? It's in the medulla. This is a location, but there are two centers there. You're going to give one of them. What are the two centers? No, baroreceptor give the signal to the medulla, centers in the medulla. What are these centers? Start with cardiac. Cardiac what? Ax, Acceleratory, and cardiac inhibitory. Yes. I'm just making sure that you guys are following. The other thing is the endocrine mechanism. Something like thyroid. Does the thyroid increase or decrease blood pressure? It works as what? As sympathetic or parasympathetic? Sympathetic. So thyroid, this is a hormonal control, isn't it? Yes. The one control, this is what we talked about. The one control that we didn't talk about is auto-regulation. What's auto means? Self-regulation. So do you regulate yourself? Yes. The different organs and different tissues, they regulate themselves. How? If too much blood is coming to it, it's going to decrease it to itself on a local level. Okay? This is like if the water is coming too much to you on your own level in a house, you can close the water tap, right? But the control out there, they can increase the whole water going to your city, right? To your city, this is a neural mechanism. This is the endocrine mechanism. It's the whole thing. But on your local level, inside your house, can you shut down the water? Can you control it? Yes, you can. You don't have to. Do you have to call the city to decrease the water coming to your house? I don't have to. I can just change the valve, right? It's the same thing. Any tissue can regulate itself. If too much blood is coming to me, I'm going to decrease it, contract the valves so that less, or the muscles, sphincters, so that less blood come to me. If there is coming, so too much blood, I will decrease it because I want much blood. Too low, less blood, I will increase it because I need enough. Everything is just common sense. I need just normal amount, not too much, not too low, right? That's everything in the body. This is homeostasis. I want everything to be normal. Okay? Anything that you think about. How about oxygen? Oxygen, that's great. Do you want extra oxygen? No, that's bad. How about glucose? This is a nutrient, right? Is high glucose good? Of course not. Even carbon dioxide. Carbon dioxide is bad. Isn't it waste product? Do you think low carbon dioxide is good? No. Low carbon dioxide, it will mean alkalinity. Do you want alkalinity? No. So the bottom line is the whole entire body wanted everything within the normal range. Whatever you think about it. It goes high, that's bad. It goes low, that's bad. Cholesterol. We all fight to avoid cholesterol, right? Do you think you can live without cholesterol? No, you cannot. Cholesterol, it's bad. Yes. Everything has to be within a normal range, whatever it is. Okay? So here is the auto regulation. Simply, it's all homeostasis. Too much blood is coming, precapillary sphincters contract, less blood go to you, coming back to normal. If it is low, dilate your own valve or your own sphincter, more blood come to you. Is that clear? If the water in your house goes down, open the water tap. If it goes high, close the water tap. I think it's clear, right? What's the water tap? The precapillary sphincters. Open it. If it is low, close it. If it is high. Clear? This is auto-regulation. But the thing is, how do you actually open it and close it? Like, does the blood like go and change it, or how? What's the mechanism? No, it is by controlling the chemistry of the blood. So when oxygen and carbon dioxide, basically, if I'm receiving low blood, is that good? I want it to increase, right? How to increase it? Well, think about it. If low blood is coming to me, it means I will have low oxygen, isn't it? And I will have high carbon dioxide, right? Low oxygen and high carbon dioxide, it's what's going to dilate the precapillary sphincters. This is the mechanism. Did you get it? So this is about this part, autoregulation. Endocrine, different organs. One of them is thyroid hormones, is an example. Erythropoietin. Let's see if you're following or not. Erythropoietin. Where does it come from? From the kidney. As a result of what? hypoxia, and low blood. So what's the effect of erythropoietin? It increases the production of what? Blood cells. And that results into increasing or decreasing the blood pressure? Increasing. So what's the effect of erythropoietin? Increased blood pressure. This is another hormone. Thyroid. Yes, this is another hormone. And so on. And the nervous control, simple is what I already mentioned. Autoregulation is vasoconstriction and vasodilation controlled by blood chemistry. And when I say blood chemistry, always, I mean oxygen, carbon dioxide. And the third one is pH. pH is directly related to the carbon dioxide. Let me ask you a hard question. If the carbon dioxide increase, what happened to the pH? Increase, decrease, increase, decrease. Carbon dioxide goes up. pH decrease. How? Why? What's the relationship? Carbon dioxide and pH, what's the relationship? It is carbon dioxide high and oxygen low. Yes. But the question is, what's the link between carbon dioxide and pH? Why is it related? Carbon dioxide dissolve in what? React with what? With water. To make what? It's hydrogen ion, but before it. What do you call it? What is carbon dioxide and water? Carbonic acid. Carbonic acid. So this is the relationship. Carbon dioxide goes up, pH goes down. What's the relationship? Because carbon dioxide goes up, react with water to make what? Carbonic acid. Carbonic what? Acid. So the pH goes down, right? So what actually dilates the blood vessels? Local vasodilation. Oxygen goes down. This is one. Carbon dioxide goes up. That's two. Hydrogen goes up, which is pH going down. Three. Other things like potassium, lactate, and nitric oxide. I want you to remember the local vasodilators. Okay? Oxygen, carbon dioxide, pH. This is the chemistry of the blood. The three that I mentioned already. Add potassium and nitric oxide. High potassium is a vasodilator also. Nitric oxide is a gas or a chemical that also vasodilates. And the nitric oxide simply is the base for Viagra and Cialis. I think we all hear about this. Viagra and Cialis. It's carbon oxide. Okay? Nitric oxide, I'm sorry, nitric oxide. They work on the nitric oxide. Look at this. What's the nitric oxide doing? Vasodilation, right? So they use this theory to produce this medication. It increased nitric oxide, and that vasodilates the blood vessels going to the penis, and that's going to lead to erection, and this is the basis. So Cialis and Viagra is nothing but nitric oxide. Just increase the nitric oxide. It's not hormones, it's not anything else. Nitric oxide. And we will talk about that in reproductive system. The cardiovascular centers, we talked about those, the acceleratory and inhibitory. So what are the cardiac acceleratory and inhibitory centers? What does it control? Does it control the stroke volume or the heart rate? From the name. Heart rate. It's called acceleratory. What's acceleratory means? What does it mean to accelerate? Higher speed up, which is high heart rate, right? Instead of 60 per minute, it's 80, 90, right? So acceleratory, accelerate the heart. Inhibitory, slow down the heart. Make sense? But is that the only thing that we can control through our nervous system? No, there is also the vasoconstriction and vasodilation. Vasodilation decrease blood pressure, isn't it? Vasoconstriction increase. Does that make sense? All these factors controlling the blood pressure. So we do have vasomotor centers in the same spot that's in the medulla as well, but this is controlling something else. Cardiac acceleratory and inhibitory, this only control the heart rate. Are we talking about the heart rate only? No, how about constriction and dilation? There is vasomotor centers that cause contraction, and vasoconstriction, and vasodilation. These centers are also located in the medulla. And you always have this tone, partial tone, that's contracting a little bit, so you don't start from zero. And here is a reflex that I talked about, baroreceptors and chemoreceptors. What baro means? Pressure. And what's chemo? Chemistry. What do we mean by chemistry? Three things: pH, oxygen, and carbon dioxide, right? So these are the chemoreceptors, right? How about the baroreceptors? Pressure. Okay, which one of those is sinus and which one is body? Chemoreceptors and baroreceptors. One of those is called the sinus, and one of those is called bodies. Do you remember it's located in the same spot? In the aorta and the common carotid? Do you remember those? No? Those two centers or receptors are located in the same spot, but they have different names. It's not called just chemoreceptors and baroreceptors. Yes, this is what it's called, but it's located in the what? The position in which it's located. We call it sinuses and bodies. The sinus is for the baroreceptors, and the bodies are for the chemoreceptors. Okay? Baro, sinuses, chemo, bodies. Baro, sinus, chemo, body. So when the blood pressure increase, you want it to do the opposite. You always need everything to be within the normal range. Isn't this is the goal of the homeostasis? Everything in the normal range. Blood pressure goes up, I will bring it down. If it goes down, I'll bring it up, right? How to do that? Well, I can control by different things, including the cardiac acceleratory and the vasoconstriction. This is one side, versus cardiac inhibitory and vasodilation. Is that clear? We have two sets of centers. Acceleratory versus inhibitory, this is one, and constrictor versus dilator, this is another one. Which pair increase the blood pressure? Acceleratory and constriction. And which pair decrease the blood pressure? Inhibitory and dilation. So this is how we control the blood pressure. I talked about the baroreceptors. I talked about the Bainbridge reflex. Do you remember the Bainbridge reflex? Where is it? Where is it located? Bainbridge. I told you this is a term that I want you to know. Where is it? Bainbridge. Atrium, yes. It's in the atrium. So Bainbridge reflex is in the atrium. And this is a reflex. When more blood come to you, you contract more to push it. Bainbridge reflex. Because of the stretching of the right atrium. Okay, so this is the whole thing together. If the blood pressure goes down, baroreceptors get it, and medulla oblongata will use the cardiac inhibitory and the vasodilators. Cardiac inhibitory slow down the heart, vasodilation, blood pressure goes back, and vice versa. If the blood pressure goes up, baroreceptors pick it, send the signal to the medulla oblongata, stimulating what? If the blood pressure goes up. And if the blood pressure goes up, inhibitory. Yes, because you said inhibitory and somebody else said the acceleratory. Inhibitory plus vasodilation. Yes. Here are the chemoreceptors. It's monitoring the blood chemistry. And these chemoreceptors, I told you, it's located in the aorta. We call it aortic bodies. And in the carotid. We call it carotid bodies, right? Those two spots. But these are the peripheral ones. What do you mean peripheral? Anything in the central nervous system, we call it central. Outside of it, we call it peripheral. So what are these receptors that I just talked about? These are the peripheral ones. Do we have central ones in the brain? Yes, in the hypothalamus. We have chemoreceptors in the hypothalamus and in the medulla as well. So you do not monitor the blood chemistry only in the aorta and carotid. This is the peripheral ones. You also, additional one, you have it inside your brain. in the hypothalamus and the medulla oblongata, it also detects the same three: pH, oxygen, and carbon dioxide. So you have two mechanisms. One of them is peripheral and one of them is central. Monitoring the same thing, yes, you're monitoring the chemistry of the blood, but in two spots, like you're having two cameras, one outside and one on the top of your house, for example. So you're monitoring, you're making more monitoring in and out, in central and peripheral. Endocrine, I talked about it. And this is epinephrine, norepinephrine, thyroid, and so on. Epinephrine, norepinephrine, what are these? Sympathetic. So what does it do? Increase blood pressure. How? What does it do with the heart? Sympathetic. What does it do? Increase heart rate? Increase heart rate. What else? How does it increase the blood pressure beside the heart rate? Vasoconstriction. Yes. Vasoconstriction. How about the parasympathetic? Yes. Okay. This is epinephrine and norepinephrine. ADH. This is physiology. You have to understand it. There is no memorization here. This is not anatomy. Anatomy, what is this? What is this? What is this? It's memorization pure. Okay? This is physiology. You need to understand. ADH, anti-diuretic hormone. What does it do? That was an endocrine system. What does it do? Reabsorb what? Water. Reabsorb water. So what happened when you reabsorb water? What happened to the blood volume? Increase. So what happened to the stroke volume? Increase. What happened to the cardiac output? Increase. How about the blood pressure? Increase. So what the ADH does? Increase blood pressure. How? Reabsorbing water. By that, you're increasing the blood volume. Clear? This is ADH. What if you don't have enough ADH? Blood pressure goes down. Angiotensin 2. We talked about this and asked you about it before. Okay, what is the first one that come from the liver? Angiotensinogen. Angiotensinogen, yes. And angiotensinogen become angiotensin 1. How? Renin. Angiotensin 1 become angiotensin 2. How? ACE, which is angiotensin converting enzyme, ACE. Okay, if you forgot, that's okay. I'm reminding you, right? So ACE, now we have angiotensin 2. Does the angiotensin 2 increase or decrease blood pressure? It's called angio what? Tensin. What's tensin? Tension. So yes. So does it increase or decrease? Increase the blood pressure. It's called angiotensin. Tension. Tension is pressure, isn't it? Angiotensin. It increases the pressure. How? Vasoconstriction is one. What else? You're not, this is not going anywhere, by the way. I told you when we did the endocrine system that I'm going to repeat this several times and you will see it again. This is not the only time. You will see it in different systems again. So how does it work? Angiotensin 2, vasoconstriction is one. What else? Excellent. Yes, it's all of this together. Vasoconstriction is one. Thirsty. What happened when you feel thirsty? You drink more water, and what happened to the blood volume? Increase. Clear? Thirsty. Vasoconstriction, what does that do? Vasoconstriction, increase or decrease blood pressure? Increasing, this is two. Aldosterone, what does it do? What exactly does it do to increase the blood pressure? What is the work or the job of aldosterone? Reabsorption of sodium. And what happened when you reabsorb sodium? What followed? Before water. Yes, water will follow, but what follows sodium first to make it salt? Chloride. So sodium, shadow of sodium is chloride is a shadow. You reabsorb sodium automatically. You don't have to do anything. Just reabsorb sodium, chloride will follow. If you get rid of sodium, chloride will follow. Chloride is nothing but the shadow of the sodium. Sodium followed by chloride. Sodium chloride is salt. What follow the salt? Water. So that will lead to increasing salt in the blood and water, right? and that increased blood pressure, isn't it? ADH, we just talked about it. It increased blood pressure. So 4 ways to increase the blood pressure. This is not going anywhere. You're not going to get rid of it. You will see it over and over again. So it's better to remember it. Erythropoietin, does that increase or decrease the blood pressure? Increase. It increase viscosity, isn't it? Okay. Natriuretic peptide. It's called natriuretic. What's natriuretic means? What's nat and what's uretic? What's nat? Uh, Na. What's Na? Na is sodium. Natter is sodium. What's uretic? Urine. So what's natriuretic means? Sodium in urine. This is a direct translation. It's called natriuretic. Sodium in the urine. That's it. You throw sodium in the urine. What's follow? Chloride first. Now we have salt in the urine, right? What follow? Water. And what happened to the blood volume? Increase or decrease? Decrease. Blood pressure? Decrease. So what's the effect of those two natriuretic peptides? Decrease blood pressure. Where are those? One in the atrium and the other one in the brain? In the ventricle. Why did you call it brain? Why did you call it atrial, a brain natriuretic peptide? It's in the brain of the pigs. This is where they found it. Is it in the pigs only? No, in us, it's in the ventricles. Why you didn't change it? Why don't you call it atrial natriuretic peptide and ventricular natriuretic peptide? Make more sense, right? Yes, you asked them. I don't know why they didn't change it. They should change it. I mean, you found it, you discovered it in the brain of the pigs. Okay, but how about us? Where do we have it? In the ventricles. They should change it. They didn't change it. That's okay. We will remember it anyway. Um, Now, the blood supply to specific organs is something that we need to know. We talked about part of it. The general systemic circulation, I'm not going to worry much about it, and I'm not going to ask you about it either. So I'm not going to ask you about like the axillary and the brachial, and you remember these? That was in your exam. This is lab. So I don't worry much about it in the lecture. I worry about what we didn't talk about, which is the special circulation. So the first one is the blood supply to the brain. Blood supply to the brain, the problem with the brain is you cannot stop oxygen for more than few seconds for the brain. The brain is very sensitive. So you need to make sure that enough supply go to the brain all the time. How to maintain that? By having two different routes go to the brain just in case if something happened, right? Like all house every single house you have just one pipe that's bringing water, right? But if this is something that's very important, you can have three sources of water, right? If that shut down, I have this. If something wrong happened here, I will have this. This is exactly what's happening in our brain. The blood comes from two different sources that are separate to the extent of if one of them completely shut down, you don't die. And I've seen it before in a hospital. Okay, that somebody was having 90% blocked internal carotid artery and he's just dizzy. It's almost 100% like blocked. And he's just dizzy. How? Because there are four sources, two in the front and two in the back. All of this is happening at the same time. So there is right side. Do you remember the carotid artery? Of course, right? So there is internal carotid artery on the right side, go to the brain. On the left side, same thing, go to the brain. In the back, vertebral arteries also go to the brain. So I have four sources, two in the front and two in the back. All these four, they come together to make a circle. And this circle is called circle of Willis. Do you remember this? It was in the lab in 233. Do you remember this when we opened the brain, the head, and look inside? So this is the circulation, special circulation, which is called circle of Willis, circle of Willis. And what happens if the blood supply to the brain shuts down? We call that stroke or cardiovascular accident, right? Is that a complete shutdown that lead to death because of from no oxygen, or this is mini stroke, partial stroke? No, this is a complete one. Stroke, translation, this part died. Died from what? Specifically deprived of blood, not just any death. There are so many types of death. Death due to deprivation, specifically, is called infarction, or in this case, it's called stroke. It's infarction of the brain. Okay? This can happen from different things, but the other one was transient ischemic attack. The one that's partial that you're talking about. It's called transient ischemic attack. I mentioned before that epinephrine and or not epinephrine in peripheral circulation, they dilate, right? Or they constrict if you wanted to increase the blood pressure. They constrict actually mainly to increase the blood pressure, right? But for the coronary circulation, that was in your exam, coronary circulation. Remember, right coronary artery and left, all of these. The epinephrine here, it dilates because the heart need more blood to go to it. Here is heart attack. Heart attack is equivalent to stroke. Heart attack, stroke, same thing. When you stop, complete stop, the blood supply to the brain, you call it stroke or cardiovascular accident, cerebrovascular accident. And when you stop the blood supply to a piece of the heart completely and it dies, you call it heart attack. Heart attack. Is that different from angina? Yes. Angina is not complete. Are we following? Less blood to the heart, angina. No blood is heart attack. Okay? Infarction. Same thing for the brain. Transient ischemic attack, less blood. The cells of the brain died? No, it didn't die. Okay? But if it completely shut down and dies, we call that stroke. So differentiate between those. Lung, we talked about it already. Remember the pulmonary trunk, right and left pulmonary arteries, dividing until it go to the capillaries, exchange. What kind of exchange happen in the capillaries of the lung? Oxygen goes into the capillaries or out of the capillaries? Into the capillaries. And what goes out of the capillaries? Carbon dioxide. And you breathe it out, right? So this is a kind of exchange. And here is one thing that's autoregulation that you have to remember about the pulmonary circulation specifically. And this is type of autoregulation. How the blood autoregulates itself in the lung. If there is low oxygen, what are you supposed to do? If you're following with me, do you remember the autoregulation that I talked about? When less blood and less oxygen go to you, what do you do? Do you dilate for yourself or constrict? Dilate because you need more, right? Here it's the opposite. If there is the oxygen is low, you constrict. How? How is that happening? Yes, because this is we're not talking about feeding the lung, which is what we were talking about before. This is about the function of the lung. Okay, if this area of the lung is not working good, don't send the blood to it because it's not working. Did you get the idea? This piece of the lung is not working good. It doesn't have oxygen because it's not working good. Should I still send a lot of blood to it? What are you this is waste, right? So in this case, you constrict. And this is a specific autoregulation to this part. What's the effect of exercise? This is another type of adaptation. Light exercise is going to increase when you exercise, you increase the venous return, increasing the stroke volume, increasing the heart rate with a light exercise. Heavy exercise, what's bad about the heavy exercise and you're not supposed to maintain it for a long time? Sympathetic. This is the most important word. heavy exercise, you activate the sympathetic. You can go to the maximum. Remember when I told you guys, if you are using the treadmill, there is a limit. Remember that the reserve, right? So you're because you're using the sympathetic, and the sympathetic will push your heart and your cardiovascular system to the maximum. But you should not exceed the maximum because you are abusing your heart. So there is a limit that you cannot exceed, and you can go to the maximum. So during exercise, simply there is a redistribution of the blood. What do you guys think if you're exercising? Do you send more blood to your muscles or to your digestive system, urinary system, and reproductive system? To the muscles. It makes sense, right? And if you're relaxing, less blood to the muscles and more to the other things, right? With hemorrhage, what happened to the blood pressure? Hemorrhage. What's hemorrhage? You're losing blood, decreased blood pressure, right? What's your reaction? Do you want to react by increasing the blood pressure or decreasing it? Decreasing is what's happening. What's your reaction? You have to restore it. You have to increase it back. This is called adaptation. I'm not talking about the act. I'm talking about the reaction. Act, you lost blood, blood pressure drops. Okay. What's your reaction? Restore it. So here it is, carotid and aortic reflexes, sympathetic nervous system, and hormonal control. All of that will help you short term to maintain your blood pressure if in case of hemorrhage. Does that stay forever? Like if I lost blood, a lot of blood, hemorrhage. Okay, I'm going to compensate temporarily. But is that okay? Can I stay like this? And that's it, it's over? No, of course not. If you lost a lot of blood, you need to restore it. You need to get more blood, like blood transfusion or something, right? But what can you do temporarily? You can just restore the blood pressure temporarily until you get like transfusion or something. Okay, so this is all a short-term elevation of the blood pressure to compensate you, to help you, to support you temporarily until like if this person is having an accident right now and he lost a liter of blood, 2 liters of blood, this drop can lead to death because less blood is going to the brain, isn't it? So what's the reaction? Temporarily, you're going to increase the blood pressure to give more enough blood to your organs until they transfer you to the hospital and then you give you blood, right? So this is not a long term. Shock is dramatic decrease in the blood pressure, and it should compensate. You can compensate up to 20%. I want you to remember this number specifically, okay? If you lost up to a liter of your five, 20, like you can lose a quarter, half a liter, 3 quarters, up to a liter, you can compensate for that. More than 20%, you cannot compensate. It will lead to shock. What's the shock? Dramatic drop of the blood pressure. All of a sudden, like, did you see somebody fainting? Like after losing a lot of blood, fainting is shock. This is shock. So if you lost more than that, up to 20, like if this is an accident, you lost half a liter, you can work around, you can compensate. Up to a liter. More than that, shock. They have to do something for you immediately. So this is a definition of shock that I want you to remember, and I want you to remember the 20%. Beyond the 20% is shock. Long term, the other things. Erythropoietin will help you to make more blood to compensate. You reabsorb more water, AGH. It's all about angiotensin 2. Do you remember angiotensin 2? Angiotensin 2, this one is your long term. Everything else is short term. Temporarily support you. Because this takes time. Guess what? What do you think? Do you have like AGH and aldosterone and erythropoietin that's ready to go like in the storage? You have to make it, right? It takes time to make it. So this is long term. This is a pulmonary circuit. We talked about it before. There are different circuits: brain, digestive system, arteries, and veins. We will talk about this. 14. We still have a few minutes. We end at 20, right? Okay. Um, so this is for the lung, how we can do the exchange of oxygen and carbon dioxide. And we start from the right ventricle. The right ventricle contain what kind of blood? Deoxygenated. It's sent it to the pulmonary trunk, to the pulmonary arteries, arterioles, capillaries, right? This is the same thing, right? Remember large arteries, mid-sized arteries, small arteries, arterioles, capillaries, same thing in pulmonary. It's existing. So at the level of the capillaries, you're going to exchange, kick out carbon dioxide at the capillaries of the lung and gain oxygen at the capillary of the lung. And then you go back the opposite way. What take the oxygenated blood to the left atrium? Pulmonary veins. Pulmonary veins. So here, do you remember this model? We have something looks like this, and a plastic, transparent plastic. So this is containing, remember I told you what's the red? Arteries or veins? Red here. What's the one word that trigger the opposite? Pulmonary. Red is always arteries except pulmonary. When you hear pulmonary, it's the opposite. Red is veins and blue arteries. This is the only spot. The other spot is the fetal circulation. We will talk about it later. So here is the two circuits, systemic and pulmonary. I'm not going to repeat. We talked about these vessels as well. Do you remember that model that contained all these arteries? This is more for the lab, so I'm not going to worry much about this. We already learned this, so no need to go through it again, including the veins. Do you guys remember the veins or not? Right brachiocephalic, left brachiocephalic, internal jugular. Remember this, cephalic and basilic? We talked about this. So this is more of a systemic, and I'm not going to worry much about it because we already covered it in the lab until you go all the way to uh, the whole systemic circulation. But look at this, because I don't think I talked about this part of the brain. This is specific, special circulation. So general circulation, remember the model? Do you remember that model? I'm not going to ask you about this model. It's in the lab. The model that contains all these arteries and veins. Okay, this is lab, so that's good enough. Special circulation is what I didn't talk much about. And look at this here. What is this? Does anybody know what is this? Common carotid. It will split into external and internal. Which one go to the brain? Internal. How about the external? No, to the head. External go to the head. Everything outside here. Internal inside, brain. External outside, head. Okay? And look at the sinus. This is called the carotid sinus. The aortic sinus is here. Vertebral artery is the other artery that that supply the brain, and I talked about this. It's in the circle of Willis. So circle of Willis is something that you need to know. It's one of the special circulations. Do we still remember that or not? You're still responsible for it. So here it is. Look at this. Vertebral, the joint to make the basilar. The basilar end up splitting into two posterior cerebrals. And then you have posterior communicating, internal carotid, middle cerebral, and then anterior cerebral, anterior communicating. Does anybody remember what I just mentioned? If you don't remember, you need to refresh your information. Vertebral arteries from the back, you have two. Internal carotid in the front, two. All four will come together to make a circuit. This circuit's called circuit of Willis, or circle of Willis. Okay? Start by vertebral, basilar, posterior cerebral, posterior communicating, internal carotid, middle cerebral, anterior communicating. Okay? You are responsible for it, so you need to remember it. This is a descending aorta. Descending aorta, basically, we didn't talk about it before. So this is not part of the lab. So descending aorta, the aorta that's going down. Going down where? In the thorax, we call it descending thoracic aorta. And in the abdomen, abdominal aorta. It will end up splitting into two common iliacs. Do you remember this in the lab? And the common iliac will split into internal and external, and then go to the lower limb. Okay, I'm not going to worry much about the upper limb and the lower limb because we covered it. Here are the branches of the aorta, but I'm gonna stop here, and we'll do the rest next time with the lymphatic system.